You are having surgery because you are having pain, weakness, numbness and tingling, or some other kind of neurological symptom, either in your legs and lower back or your arm and neck area. These symptoms are caused when the spinal cord or one of the spinal nerves is pinched, compressed, or does not have the space it needs to function properly. Because there are many different causes of this, your neurosurgeon will discuss your specific cause with you. We are going to talk about the common causes of your symptoms.
The discs between the vertebrae are similar to a jelly donut. When there is too much pressure placed on the disc, part of the jelly, or the nucleus pulposus, is forced out of the center of the disc. This part of the jelly can limit the amount of space available for the spinal nerves, making it so it doesn't have enough space to function properly. This is called a herniated disc. At Salem Hospital, a discectomy or microdiscectomy is performed to remove that small part of the jelly or nucleus pulposus that has herniated out of the disc.
The goal of the surgery is to remove the part of the disc that's herniated. So we're not taking the whole disc out, so the majority of the disc remains in place because it acts as a shock absorber between the bones, so you really want to leave all of the healthy disc in place.
Your surgeon will remove a small part of the lamina, the bone that wraps around the back of the spinal canal, and they will remove the part of the disc that is pinching the nerve. The goal is that after this part of the disc is removed and the nerve has the space it needs to function properly, that your symptoms will resolve. Another common cause of symptoms is spinal stenosis. Spinal stenosis is a general term, meaning that there is some kind of narrowing of the space available for the nerves.
I use the Chinese finger trap analogy that it's like it tightens up around the nerves and limits the blood supply to the nerves, and then they'll typically get relief if they sit, which would tend to create a little bit more space here, or lie down. That would tend to happen reproducibly, say within 10 or 15 minutes of walking. So that could be an example of a lumbar stenosis.
Bone growth or spurs that limit the amount of space available for the nerves or the spinal cord can be a common cause of spinal stenosis. Spinal stenosis can also be congenital, meaning that some people are born with smaller openings for the nerves and spinal cord than others. Spinal stenosis is one of the reasons that you may be having a laminectomy. Your neurosurgeon will discuss your exact cause of symptoms. In a laminectomy, part or all of the lamina is removed. Once these pieces of the bone are removed, the goal again is that the nerves will have the space they need to function.
In most of the cases we do a laminectomy, we're removing a small enough amount of bone that it minimally affects the spine. And then once the patient heals, we then feel it's important to educate the patient as to conditioning and exercises, because they can certainly make up for that weakness that has happened by strengthening their back muscles and doing it on an ongoing basis.
The final common cause of symptoms is spondylolisthesis. This is an instability of the spine. Normally the vertebrae stack every one on top of another. In spondylolisthesis, there is a shifting of the vertebrae so they are no longer lined up. When this happens, the spinal cord or nerves can get pinched. Your surgeon will stabilize these two vertebrae so they no longer shift off one another. This is done by fusing these two vertebrae together.
We don't necessarily think that every slippage needs to have surgery. We don't necessarily think that every congenital abnormality needs to have surgery. But when we find that the patient's exercising and good conservative measures fail and they start having increasing pain, then those patients we certainly think need to have surgery, be appropriately decompressed, and be stabilized. And the way we tend to stabilize is with a technique called a fusion.
In a fusion, your surgeon will completely remove the disc between the vertebrae to be fused. They will then fill this area with ground-up bone and a special type of cement. The goal is that over time this will form one solid bone, similar if you had broken your arm or your leg.
A commonly asked question is, where do we get the bone from? And there are different sources for that. A lot of surgeons actually try to use patient's own bone, and we do that by collecting the bone pieces from the decompression. If that amount of bone is not sufficient enough, then we have all kinds of different substitutes. Most commonly used form of substitute these days is probably the cadaveric graft that gets mixed with the patient's own bone.
It can take up to a year for those bones to completely fuse together properly. In order to hold the vertebrae in place during this time, your surgeon will place fusion hardware to stabilize the vertebrae. This is done by placing 2 screws into the vertebrae and holding them in place with either a plate or with metal rods.
One of the big breakthroughs, which was a little controversial when it first began as far as help in spine care, was the advent of the pedicle screw instrumentation. So now we can treat patients and stabilize them with plates and screws and various types of instrumentation that allows them to be up and moving quickly without the risk of paralysis and so forth that might take place. The success rate has improved dramatically in the fusion rate by using the pedicle instrumentation.
Generally, cervical vertebrae that are fused are done from the front of the neck. Lumbar fusions are usually done from the back.